Thank you, Teresa, and I'd like to thank the organizing committee for asking me to come and speak about pediatric and adolescent oncofertility considerations. And at first when they mentioned that, I thought, boy, that's a broad topic. And so I asked her, would it be okay if I talked about infertility risk communication? Because we talk a lot about risk for infertility and what we're going to do, and fertility preservation. But I think it's really important to close the loop on how do we talk to patients and what do patients hear? So the other subtitle is Infertility Risk Communication. It's not a simple, single checkbox. So let's start with kids are not little adults. Fact number one, pediatric cancer is different. So by definition, a pediatric cancer is cancer diagnosed before 21 years of age. They're very different kinds of cancers than we see in adults. And from the pie chart, you can see that leukemia, lymphoma, and brain tumors make up 2/3 of all the cancers in this age group. Because they're so different, I mean, we don't see breast, we don't see thyroid as much, skin cancer, lung cancer, those kind of things. Because they're so different, the treatments are different. They're multimodal, often involving surgery, chemotherapy, radiation, transplant. They're fairly aggressive, but in doing so, our 5-year survival is over 80%. So that's good, that's great. But we're also looking at decades of life after cancer, right? And also with that, the sequelae and the late effects that can come from cancer treatment. So that's cure at what cost, the sequelae of treatment. So what we know, a lot of what we know about childhood cancer late effects comes from the CCSS, the Childhood Cancer Survivor Study. And in this landmark paper by Kevin Effinger in 2006 in the New England Journal, he reported on over 10,000 survivors. Remember, all data coming from the CCSS, although it's very robust, is self-reported data. The cumulative incidence at 30 years after diagnosis for any chronic health condition is 73%. 73% of survivors were reported to have a late effect, chronic health condition, perhaps a late effect related to their cancer treatment, while 42% had a severe, life-threatening, disabling condition or a condition that had resulted in death. And this is characterized using the common terminology criteria for adverse events, the CTCAE, so it's very standardized. And this was really a sobering number. Let's contrast this to St. Jude Life, which was reported by Melissa Hudson in JAMA in 2013. She looked at 1,700 adult survivors of childhood cancer, and her data is based on physical exam and recommended surveillance from long-term follow-up guidelines. By age 45, the estimated cumulative prevalence for any chronic health condition is above 95%, a very sobering number. And 80% had a serious disabling or life-threatening condition. And I will say most survivors look great. Most pediatric cancer survivors look wonderful. But I think we all need to be aware that there's trouble brewing below the surface, that we need to be on our toes to address and hope to mitigate with early intervention. So just keep that in mind. Fact number 2 about pediatric cancer. Late effects can first appear at time points throughout the lifespan. And I think people forget this, that if they don't have a late effect by the time they enter survivorship, they're not going to get it. Or if they don't have it by age 21, they're not going to get it. Well, that's not true. And so they need surveillance throughout their lifespan. Let's give a couple examples in regards to gonadal late effects. At the time of treatment in an AYA, they can have surgical menopause. So that's a late effect that happens at the time of treatment. What about a late effect that first appears soon after exposure or early in survivor care? How about an AYA who develops acute ovarian failure? So acute ovarian failure is failure within 5 years of diagnosis, and this might occur after BMT. What about a late onset? So think about a toddler who's treated, but then never really initiates puberty. So that's a late onset late effect. So this is ovarian failure that occurs 10 years, first appears 10 years after completion of treatment. And then a very late onset, again, let's go back to our toddler who was treated, but actually, if they're treated at 3, they might not experience or be diagnosed with infertility until 30 years later. So the idea is that they need to be watched and evaluated throughout their life. So how do we monitor patients? So what we commonly use here or throughout North America are the Children Oncology Group long-term follow-up guidelines for survivors of pediatric, adolescent, and young adult cancer, the COG long-term follow-up guidelines. These are evidence-based guidelines. If you go to the guidelines, they're arranged by cancer therapeutic exposure, and they are developed by 13 organ-specific task forces. So there's an ovary task force, a testis, a cardiac, a pulmonary task force. And each task force is made up of 10 to 20 multidisciplinary subspecialists. So there's an endocrinologist, an REI, a urologist, but they all work together to review the literature and to make recommendations. They're revised every 5 years, and I'm happy to share that the new guidelines were posted last night. So the revision is up, and so those are, at least for right now, current. And this is an example from the page of the guidelines, if no one's ever looked at them. This is what it looks like. So you'll see here that we're talking about chemotherapy, and we're talking about alkylating agents. They'll give you a list of the alkylating agents that are considered in this section. Then you'll see the potential late effect here is gonadal dysfunction, testicular, which includes reduced fertility, oligospermia, azoospermia, and infertility. Then what's useful to me is this section on periodic evaluation. So this is where the surveillance comes, and it recommends what you should ask in terms of the history, the physical exam, what you should obtain for laboratory surveillance, and any radiologic studies. There's a nice section over here about counseling and further considerations. Lastly, if you look at this box, it tells you how strong the evidence is on which this guideline is based. 1 is the strongest, 2A is less strong, and 2B is a little bit controversial. And then importantly, if you want to go back and pull the literature, here are the references. So every section, every late effect has a section. But there are other guidelines, and Jen nicely talked about these, so I don't have to go into them in detail. We talked about the COG guidelines, the Dutch guidelines, the UK Children's Cancer and Leukemia Group, the SIGN guidelines, and a lot of other guidelines, and often they're used as pertinent to the topic. And as she mentioned, there is a mammoth effort to harmonize these guidelines, this group this activity is referred to as the IGHG, the International Guideline Harmonization Group. Pertinent to what we're interested in, there's been harmonization around female late effects, male late effects, hypothalamic pituitary late effects, fertility preservation in females, and obstetrical care. And these are 2 papers that have come out, and you can see there's a paper on POI from the Harmonization Group and JCO in 2016, and then a paper on gonatotoxicity surveillance in males that was published in 2017. So this takes a long time to generate, but the others are in the pipeline, and you'll see them soon. So that's a little bit of background on what we know about long-term surveillance and care in patients who've been treated for cancer. But what do we know in particular about fertility and infertility in survivors of childhood and adolescent cancer? So this is one of the things that I think about a lot, and that's the difference between fertility and infertility. And it's important to realize that infertility is not 1 minus fertility, right? So if you have a fertility rate of 60% in a population, it doesn't mean 40% are infertile, right? Right, because not everyone is in a relationship that could result in a pregnancy. Not everyone wants to have a child. So if you really want to know the infertility rate, you have to ask the right question. And you have to ask, if the patient has been unsuccessful in becoming pregnant or siring a pregnancy after 1 year of trying. That's the definition of infertility. Okay, so when it took me a long time to sort of get my head around the literature and the numbers because I was always so confused, but I think part of my confusion was around this difference, the reporting and trying to understand what they were measuring and what we were actually looking at. So let's look just from the CCSS, which has data both on fertility and infertility. So again, remember the CCSS, when we talk about rates, they are comparing survivors to a sibling cohort, a sibling comparison group. So in this study by Green, female survivors were found to be 20% less likely to have experienced a pregnancy. So the relative risk is 0.81. So here we're talking about fertility. What about infertility? In a paper by Barton, we see that female survivors are 50% more likely to self-report infertility. So here we have a relative risk of 1.48. What about in males? Male survivors are almost 50% less likely to have sired a pregnancy. Again, data from Dan Green. And then in a paper that we wrote, male survivors are more than 260 times more likely to self-report infertility with a relative risk of 2.64. So that's what we scientifically know about this area. What about, let's go back to St. Jude Life. Remember, this is where they actually evaluated patients, right? And using the recommended guidelines. So we're going to look at premature ovarian insufficiency, male germ cell dysfunction, and late egg cell failure. And these are in at-risk patients, patients that received alkylators or radiation. So for premature ovarian insufficiency, this is defined as amenorrhea and a menopausal FSH. So if we look at this, we see that they looked at 553 patients. Before the St. Jude Life assessment, 8% of patients had POI. After the St. Jude Life assessment, that percent increased almost to 12%. So again, based on physical exam and laboratory evaluation. What about germ cell dysfunction? So this was determined by semen analysis, and it had to be azoospermia or oligospermia, defined as a sperm count less than 15 million. So again, 328 patients were evaluated. A number were not evaluated because of a history of fertility or a reported infertility, or they didn't, inability to provide a sample, or for personal reasons. And before evaluation, 2.7%. After the St. Jude evaluation, 66% of the patients were felt to have male germ cell dysfunction. And lastly, looking at endocrine dysfunction, late egg cell failure, here it was a testosterone less than 250 and an elevated FSH, and the percentages were 4.4 before and 11.5 after. So those are the kind of numbers and information that we have when we actually talk to patients. But I think it's really interesting. But what are survivors' perceptions of the risk for infertility? And this is where it's really important. We talk a lot about what to say to survivors, when and how to communicate with them, but I don't think we do a lot of asking them what they heard, what they believe, and what they know. So in a study by Lillian, an online survey that was completed by 92 childhood cancer survivors aged 22 to 43 years, 82% reported they knew about their infertility risk. 75% recalled being told they were at risk for infertility, but 29% didn't believe it. I think that's sort of funny. I don't know why they didn't believe it, but they reported that they didn't believe it. So interesting, good stuff to know. What about the accuracy of those that report I'm at risk or not at risk? How accurate are they? So this is a study that we did in the CCSS, looking at 1,352 adult male survivors of childhood cancer, and we asked, are you at risk for infertility? Are you at increased risk for infertility compared to your peers who did not have cancer? So of those who received gonadotoxic treatment, so they were at risk, 36% said, no, I'm not at risk for infertility. The flip side of that is of those who did not receive gonadotoxic treatment, 35% said, Yes, I'm at risk for infertility. We are not doing a very good job. I mean, it's not their fault, it's our fault. They're walking away with misperceptions. So lots of work to be done. What about how does age factor in? So again, another study which actually looked at 48 female survivors who were at risk and 41 parents. And 58% of the survivors were aware of their risk, and 82% of parents were aware of their risk. But if we broke it down by age category, you can see that only 33% of the young survivors, 10 to 12-year-olds, were aware of their risk, and that steadily increased by 13 to 7, 56%, by 18 to 21, 87%. Now, and then with their parents, 73, 88, and 89. So I think a lot of things happen between here and here. They may or may not go into puberty. They don't go into puberty. The fact that they have gonadal damage is sort of solidified by the start of HRT. And then there are perhaps additional discussions, at least in our institution, there are between this time point and this time point about long-term female and male health late effects. So, but it's important when you look at data to realize what age survivor are you talking to. So this is a little bit busy, but let's even like hone in a little bit tighter on what they hear when when they've just had the discussion. So this is the discussion of risk for infertility at diagnosis. So this is male patients versus their parents. So this is 102 male patients and their parents. So this is 102 adolescent age males newly diagnosed and their parents. And this is within 1 week of talking to their oncologist. Okay, so I sort of messed that up. At diagnosis, talk to your oncologist. 1 week later, ascertain what did you think your level of risk was. So the oncologist said that they reported what they told the patient. So of this group of patients, none were at no risk, 33% were low risk, 41% moderate, and 25% high risk. When we look at the whole group of adolescents, 5% said I'm not at risk, 38% I'm at low risk, 50% moderate, and 7% high. In the parents, 1.3 no risk. It's interesting to me that they get no risk out of the conversation. And I have a thought about that, and I'll share it with you later. 27% low, almost 60% moderate, and 12% high. Overall, 60% of survivors reported their risk inaccurately within 1 week of having received this information. 43% underreported, 17% overreported. Parents, about the same percent. 59% reported their son's risk inaccurately, 35% underreported, and 23% overreported. So what are the consequences of this? Well, when you think about it, for people who underreport, they report a risk level lower than actual risk. There's a lot of distress as they move into survivorship, and then they learn, well, you really were at high risk, or you really were at moderate risk. And they may have regret or resentment for not pursuing fertility preservation. Likewise, what about overreporting? People who think they're at a higher level of risk than they actually are. Well, these individuals really worry a lot. They worry, they're concerned, it may impact their relationships, they don't want to disclose that they're at risk when they really aren't at risk, but anyways, and also, if they think that they're infertile, sometimes they don't practice contraception quite like they should. So then that can result in an unplanned pregnancy. So, okay, so we talked about details. What do survivors recall about the time points of discussion of risk for infertility? So this is fact number 3 that I think that we need to really pause and think about. This is the age at diagnosis for pediatric cancer. So we always talk about how important it is to discuss risk for infertility at diagnosis. They're 3. Are they really involved in that discussion? How about at the end of therapy? Okay, they're 5. No, they aren't involved in those discussions. Entry into survivorship, okay, now they're 7. So, I mean, I think we really have to think about the difference that we see in pediatric and adolescent cancer patients, and realized those are lost opportunities, not really lost opportunities, but just times that you can't have that conversation. So you have to be sure to make up for it at other times. So this is a study done by Brooke Shervin in a survey mailed to survivors aged 18 to 25 years, 61 survivors, half were male, about recalling discussions of risk for infertility and preferences at 3 different time points. So again, at diagnosis, 36% reported a recall of a discussion of risk, 39% at end of therapy, and 71% sometime in survivor care. You were more likely to recall a discussion if you were male. You can see 47 versus 24, 44 versus 35, and 72 versus 70. If you were older, which I think is interesting, right? So if at diagnosis, you were less than 13 or older than 13, so we can also think of that as the cut point at which we might start talking about fertility preservation. And so we have 30 versus 53, 32 versus 59, and 64 versus 74. Whether you're at risk or not at risk, and more likely to recall the discussion if you were at risk, and whether you participated in survivor clinic care. But patients across the board said that they would have liked to have had information at that time. So just remembering, they want information. And if they're of age, then it's important to include that. So I like to think of opportunities of points in time to discuss risk for future infertility. And if they're the correct age at diagnosis, I think, as I mentioned, if you're going to do a fertility preservation intervention, that sort of solidifies their risk, I hope, in their mind. At the end of treatment is an opportunity at entry into survivor care. So when you first come to survivor care, as part of your first visit, you receive a survivor health care plan. Survivor health care plan summarizes your cancer diagnosis and treatment, your individualized profile for late effects, risk profile for late effects, and the recommended surveillance. So as part of that, it should be mentioned that you are at risk for gonadal dysfunction and perhaps infertility. And as part of our we don't tell them what they're not at risk for except for this, because it's important to them. So we do mention you're not at risk for infertility. So we're pretty proactive about that negative. Most pediatric centers have to transition their patient at some age, and we transition at age 21, so I think it's super important that you come back and revisit this conversation before they transition. Puberty is another opportune time, right? Because they're supposed to enter puberty, their friends are, and if they don't, it's an obvious time to talk about possible gonadal dysfunction, and then you have to read the meter with their families about whether they're ready to involve the child in the discussion for risk for future infertility. One of my favorite times is actually age 18, when they assume their responsibility for their care, and I'll come back to this later, but it's a time when they're really happy to have their parents leave the room and we have a one-on-one discussion. It's like one of my favorite conversations to have with a patient. So how can we better communicate risk to survivors? So we did a study that was funded by Cure, and we looked at addressing infertility-related knowledge gaps and needs of adolescent and young adult survivors of childhood cancer. Our aim was to evaluate the effectiveness of an evidence-based educational intervention in increasing AYA survivors' knowledge of personal risk for infertility. So survivors aged 18 to 21 were recruited during their survivor clinic visit in the Aflac Cancer Center. We did a baseline survey in REDCap. We measured their perceptions of their risk for infertility and their concerns about their possible future infertility. Participants then received a parent-free, one-on-one, personalized educational intervention regarding their risk for infertility with an Oncofertility provider, aka me. Then there was a follow-up survey 1 month later after the clinic visit assessing the baseline survey questions, their preferences for education regarding their risk for infertility, and their preferences for timing of fertility status evaluations. So the goal was that they would answer these 4 questions correctly. First question, are you at risk for infertility? Simply dichotomized to yes or no. If yes, to know their level of risk, low, moderate, or high. Then I thought it was important that they know whether they had a limited number of years to have children compared to their peers. So in at-risk females, I wanted them to know that they probably shouldn't wait till they were 35 to start having children. So that would be yes. But in males, although cancer treatment can definitely be sterilizing, if they were producing sperm, they would probably continue to produce sperm. And then lastly, an important question, if you're sexually active with the opposite gender, do you need to use protection to prevent a pregnancy? And of course, the answer is yes, right? Okay, so 4 simple things that we wanted to get across. So it was a 2-phase intervention. In phase 1, we utilized the PLICIT model. And my favorite part of PLICIT, I do the others, but the P is the best part. And the P is asking permission to have a sensitive conversation. It took me a long time to learn this. I mean, I was like, okay, it's time for me to go in and have the conversation. And then I realized, no, I'm going to go in and say, hey, you know, a lot of survivors are worried about infertility. Is it okay if we talk about that today? Changes the dynamic of the conversation totally. So P is my favorite part, but I also give limited information, specific suggestions, and if they totally fall apart, I call my psychology colleagues to help me with the intensive psychological therapy part of it. Right, James? I then used a gender-specific laminated collateral. I talked about what hormones tell us, LH, FSH, estradiol, and AMH in females, LH, FSH, and testosterone in males. Talk a little bit about the hypothalamic pituitary axis, what oligogonadotropins mean. Talked about the window of fertility and DOR and potentially early menopause in females, and if they were making sperm, the lack of a restricted window in males, level of risk for infertility, and the need for contraception. Other key thing, use teach-back. So I've learned teach-back from my nursing colleagues. This is the best thing. What you do is after you've had the discussion, you ask them, you ascertain the patient's understanding of the 4 key concepts in their words. If the patient's responses are incorrect, try a new approach. Just don't teach it again. Try another approach because it didn't work the first time. So be creative and think of another way to sort of explain it to them. And it's an iterative process. We keep doing it until they get all 4 key concepts right. Should work, right? This should work. So after phase 1, we evaluated the effectiveness, we modified the intervention, and then we recruited patients for phase 2. So these are the data from phase 1. And I got to tell you that these conversations were great. And we were all at 100% at the end of the intervention. I thought, we won't even need a phase 2. This is going to be wonderful. No. Okay, so for infertility risk, the light blue is at baseline. So 64% were correct about dichotomized to yes or no whether they were at risk. The gray bar indicates 100% were right before they left. But 1 month later, only 76% dichotomized, yes or no, got that right. Infertility risk level, 35% at baseline, 52% in follow-up. Window to have or father a child, 70% at baseline, 91% at follow-up. To me, this is like the hardest concept, but they seem to get this. I still don't quite understand that. The need for protection for pregnancy, 54%, and then 70%. I don't know what to say. But anyways, only 70% thought they needed protection. So obviously we needed to improve. So we modified the educational intervention, and we developed a personalized handout that I gave them to take home. And the message was that the follow-up in a month, it's an open book test. I don't care if you pull this out. That's great. Life is an open book test. You're going to Google it or something else, so pull this out. Okay, this should work great, right? Okay. So the handout, now I have low, moderate, high, and I put a big arrow at where their level of risk is. I give them their serial laboratory values so that they have them, and especially for females, it's important if they're going to see an REI. Now they have their FSHs and AMHs over time. I tried to be a little bit cute and say, if you don't want one of these cute little babies, use a condom every time, and then I go into, why do you use a condom, to prevent STD and to prevent babies, and okay, so I tried to appeal anyway to them to be sure to use protection. And then this is the take-home points. Okay, so we answered this together. I circle the right answer for them and give it to them. Okay, all right, so here we go. These are the comparison of the phase 1 and phase 2 participants, and they're no difference by gender, race, age at survey, age at diagnosis, time off therapy, cancer diagnosis, education level. Their infertility risk level, I do want to point out that 84% in phase 1 and 70% in phase 2 said one day they wanted to have a child. So this is important to them. A lot didn't know, and I would expect most patients that age to say, I don't know. The amount of time spent in teaching was not different in the 2 phases, and the number of patients that required reteaching was not different either. So let's compare the results with the take-home handout. So again, we've already seen phase 1. In phase 2, very similar baseline values, but dichotomized to yes or no, we're up to 92%. In terms of infertility risk level, there was a significant increase from, again, in the 30s up to almost 90%, recognizing their level of risk. Window of time to have or father child, again, they get this concept and they're doing great in follow-up. And then the need for protection. Okay, great, we improved, right? We improved. We're up to 81%. But guys, that means 1 in 5 still don't think they need protection. An area of improvement. I am open to suggestions. I just don't know. Okay. So when I talked to them about their preferences, did they find the conversation with the provider on your risk for infertility to be helpful? And then we divided them into females and males. 2/3 of all females said it was very helpful, and no one said it was not helpful. So that's good. They liked the conversation. And guys, you know how they're like, yeah, slightly moderate health is great. So 2/3 said that was good. Then I asked, would you have preferred your parents in the room for the fertility discussion? 2/3 of the girls said no, but 1/3 did. So that's important to remember. Again, let them choose. Ask them. It's like the permission thing. Let them choose whether they want their parents. But by far, the guy said, no, I do not want my parent in the room. I like the discussion. I don't want my parent in the room. And then I was interested, so in the at-risk survivors, I said, would you be interested in additional testing to assess your fertility status prior to transitioning to adult care? Because once they go to adult care, I'm not holding their hand. I mean, I know all the adult providers out there hate us pediatric providers because we hold our patients' hand. We do everything for them. We call, we make their appointments. We remind them when they miss their appointment. But it's like, okay, you sure you don't want this before you transition? And in general, nobody wants it like this year. We'll see whether they want it next year. But like 50% of the girls, 34% of the guys said, yes, I'd be interested in doing this before I transition. And most of them said maybe within the next 1 to 5 years, which sort of makes sense too. I think we just need to give them the information. So what did we learn from the study? The majority of survivors would like to have a child one day. Survivors find opportunities to discuss their risk for future infertility helpful. Personalized information provided in the handout given to patients to take home improves knowledge of infertility risk. Patients' preferences need to be taken into account in planning an educational approach and may be impacted by gender. And clear communication strategies around pregnancy prevention need to be developed. So how do we translate this clinical research into practice? So I sort of divided this up into who, what, when, where, and how. Who needs to have, we call it the male health talk or the female health talk. Certainly all at-risk survivors, right? And those in pediatrics by the COG guidelines are individuals who have received alkylators, heavy metals, gonadal radiation, hypothalamic radiation, and pelvic or GU surgery. But also not at-risk survivors. Many survivors not at risk think they are at risk, okay? So talk to them too, because we don't want them worrying and we want them to use contraception. So what are you going to talk to them about? So at-risk survivors, talk about the level of risk. If it's before cancer treatment, as in fertility preservation, focus on that and interventions that maybe are available to them. After cancer treatment, I think we want to focus on fertility status assessment, which includes maybe seeing an REI, getting a semen analysis. Talk about that window of fertility. The one thing we don't want are girls that are having periods now and think they're fine, and then the window closes and they said, I wish I would have known. I wish someone had told me. And I think it's really important, even in high-risk girls, to discuss family building options. I always say there are lots of ways to build a family. And we talk about egg donation, we talk about embryo donation, we talk about all the great stuff that goes on at this conference. We talk about fostering, we talk about adoption. But I want them to leave optimistic that if they want a family, we'll figure it out. Not at risk survivors, again, reassure them, tell them not to worry unnecessarily, and in all survivors. I think I've driven this home enough times. Pregnancy prevention and STD prevention. But keep it simple. It really has to be simple, especially in these AYAs. I mean, it has to be really clear messaging and keep it simple. So when, again, at diagnosis, you might have to just involve the parent because it's a young child. You may just involve the patient. So if it's an older patient who's been diagnosed, I actually think this is a conversation perhaps you have with the parent and then the patient, and then maybe you have it together. But I do think that again, it's not like, okay, checkbox done, I talked to the parent. That's not enough. You may have to have, it may take a little while to be sure that you you have the right conversations with everybody. During therapy and at the end of therapy, so this is important, and we're back to the oncologist having the discussion. The oncologist is a trusted provider, and it's great if they will talk about their risk for infertility, but again, sometimes they're comfortable and sometimes they're not, and so then they call our fertility team, and we are happy to talk with them. As I mentioned, entry into survivor care, review the survivor health care plan, discuss with patients at risk and those not at risk, at puberty, if they don't go into puberty, if they don't initiate puberty, if the surveillance labs are worrisome. Okay, so in our practice, we currently at age 13 in girls and 14 in boys get gonadotropin, sex hormones, and AMH in girls. So if those are off, that's an opportune time to have the discussion. And then anytime they bring it up, I think, don't get hardwired into puberty, 18, and those kind of things. If they're 9 and they bring it up, and the mom brings it up, or the kid brings it up, have the discussion. So my favorite time at 18, you really do have a great option for a parent-free discussion, talk about fertility assessment, and males talk about semen analysis. And then I always try to double back at 19 or 20 because they're going to have more questions. And they're going to, oh, you're the sperm doctor. Yeah, okay. Yeah, let's talk again. Can you help me get that test done? And I'm like, yeah, I can help you get that test done. So sometimes I think, like when I first did this, I was like, I don't even know how to start this conversation. This is really awkward. And so I put on here some opening comments that I have that sometimes they were initially very helpful to me to know how to even start. So I'll walk into a room and there's a 17-year-old, 18-year-old, 19-year-old, and I'll say, when asked about their concerns regarding their future health, young adults often list cancer recurrence, getting another cancer, or worry about inability to have children as their top health concerns. Do any of these worry you? Almost every time I've gotten yes. And I'll say, well, what worries you? And I would say 3/4 of the time or more, it's having kids. I don't know who to ask, can I have kids? They really don't know who to ask at that point. They feel awkward asking their parents, and so they don't really know where to get that information. The other thing I'll use is studies have shown that nearly 1/3 to half of pediatric cancer survivors have incorrect perceptions of their risk for future infertility. So we set aside time during your survivor clinic visit to talk about personal risk. Would you like to have that talk today? Would you like to talk about that today? So that's an easy way to sort of normalize it, saying a lot of people don't know. Is it okay if we talk about it? And I would say maybe a handful of times I've had people say, I don't want to talk about it. I say, okay, that's fine. Check you next year. So I think it's important to respect their wishes. How to do it? Okay, so this is the handout we use. Ask permission, provide a handout, review their exposures, mark their level of risk. Okay, this is the pearl. When I talk to patients, I say, you're at risk because you received alkylators. You're at risk, your risk is low. You know what that translates to in their brain? I'm at low risk, which means like below normal risk. And the first couple times I went, what? And then I said, no, you are at risk because you got that kind of treatment. And the patient looked at me and said, oh, Dr. Meacham, I get it. Low does not mean low. Low means low. And I went, yeah. And so I use that all the time now because that was a blind spot for me, that they would think low was below peers. So do be careful with that if you say you're at risk but it's low risk. And then provide them the personal data. Talk about the window of fertility. I always say if they have cryopreserved reproductive material, I always say, my hope is that you'll never have to use this, that you have kids naturally. Try, but if you're unsuccessful, then you've got this insurance policy, and let's see how we can get you to the people that can help you use it. I also say, see this picture of these cute babies, it reminds me to tell you that that your children are not more likely to have birth defects, because they worry about that too. And also, if you don't want one of these, use protection. Do you know why and what protection gives you? And then talk to them about fertility status assessment if they want that. So when I do teach back, I'm always careful to say, this is not a test of you, it's to see how well I communicated these concepts, because I think that's real important. I'm not giving you a test. I'm trying to see, did I communicate it well? Let them answer. I'm not so good at that either. Sometimes I jump in. Reteach with a new approach, and it's iterative. So, take-home message. Once is not enough. These are all times at which to consider having the conversation, and it's not a checkbox. If you've done it once, it doesn't mean you don't need to do it 5 more times. And to be successful, we need to assess what they heard. You've got to double back and see, what did they believe, what did they hear, what did they perceive. So I want to say special thanks to the amazing fertility team that I have the privilege of working with. We're blessed to have lots of different kinds of specialists, and we work hard and we play hard, and I'd be happy to take any questions or get your suggestions on how you communicate risk to patients. Thanks.